Hello, I'm Dr. Ziad Khatib from Nicklaus Children's Hospital Cancer and Blood Disorders Center. Welcome to our physician chat episode. Today we're going to talk about pediatric brain tumors. I'd like to do is to give you an update on the latest developments in childhood brain tumors. As you may know, pediatric brain tumors are the most common solid cancer in childhood. In the United States, we have approximately 2,500 to almost 3,000 new cases in children every year. The cancers that we see in children are predominantly sporadic by chance. However, there is a 10 to 15% incidence of genetic cancer predisposing syndromes, for example, neurofibromatosis, tuberous sclerosis, and some others such as Li-Fraumeni and genetic predisposing syndrome for cancer. So it's important to know that because you don't want to miss one of these syndromes. The clinical features that a pediatrician or any clinician should know when it comes to brain tumors is that the symptoms are related to the location of the tumor. The majority of pediatric brain tumors are in the posterior fossa or infratentorial. So the signs and symptoms are usually those of hydrocephalus, increased intracranial pressure, for example, headaches and vomiting. When the tumor is in the supratentorial area, such as in the cerebral cortex, then the symptoms would be more like seizures or neurological deficits. And the rare tumors that occur in the spinal cord would present with weakness or bowel or bladder dysfunction. One of the latest developments in pediatric brain tumors is neuroimaging. Of course, we're familiar with MRIs or magnetic resonance imaging, but we also have MR spectroscopy, functional MRI, and a variety of other technologies which are all available at Nicklaus Children's Hospital. To give you an example, when a neurosurgeon is trying to approach a brain tumor, such as in this image, you can see that we can delineate the brain with an MRI, but we can also look at the functional locations of certain areas. For example, in this area, we can see the expressive language activation center in relation to the tumor so that the neurosurgeon can target the tumor without any damage to speech or language comprehension. So, following our imaging, the next step is neurosurgical intervention. And there are many new techniques that have developed in the last decade. For example, endoscopic surgery, neuronavigation and monitoring, and intra-operative MRI. As well as some other techniques to ablate or focus on a tumor and remove that without any major surgery. This is an example of an intraoperative MRI, which is also available at Nicklaus Children's Hospital. The advantage of that is when a surgeon removes a tumor, they need to know whether the tumor is completely gone or there's any residue. In pediatric brain cancers, it's very important to remove as much as the tumor as possible, preferably a complete or what we call gross total resection. And this way, the surgeon will know immediately at the end of the surgery whether the tumor is removed completely or if they have to go back in and remove what's left. When the tumor is removed, the next step is neuropathology. And nowadays, we have sophisticated techniques. It's not just immunostaining or referring to tumor as a blue round cell or a fried egg appearance, as we used to call some tumors in the past, but we have cytogenetic, molecular, and methylation or RNA expression techniques that can identify the DNA fingerprint of a tumor. And this is the latest WHO classification for brain tumors, and if you look closely at this table, you'll see that there is both the histological classification, but there's also some molecular elements there that are important for classifying some of the new tumors, and we'll talk a little bit more about that in detail as we move forward in the talk. This is a paper that was published in Nature in 2018, and we had the privilege to be a part of this publication, looking at DNA methylation-based classification of brain tumors. And for example, if you look at this figure, it shows you that brain tumors are clustered based on their genomic expression of RNA. So this is called methylation-based classification. And you can see that each category of pediatric brain cancers clusters in a certain location based on the DNA expression. And this highlights why this is important. On the left, you can see a list of tumors classified by a pathologist based on regular histology. And on the right, you see how the diagnosis was changed based on this molecular classification. And what we found that around 10 to 12% of diagnoses were changed, sometimes from benign to malignant, sometimes from malignant to benign, based on this molecular classification. I'm going to talk briefly about some of the most common pediatric brain tumors that we see. The most common brain tumor in children is astrocytomas. And the treatment for astrocytoma is predominantly surgery. If the surgeon can remove that tumor, then no more treatment is necessary. However, there are situations where the tumor cannot be removed. For example, if it's in the midline, such as in the brainstem or midbrain or thalamus. And in those cases, we have a variety of chemotherapy regimens that we use to shrink or control those tumors. But sometimes radiation or chemotherapy is not sufficient, and in those cases, we use proton beam radiation, which is also available in Miami. Now, to look more deep into the astrocytoma histology, I'd like to point out that now, as I mentioned, we rely on molecular classification. So what we found is that astrocytomas are a disease entity that affects the MAP kinase pathway in the cell cycle. If you look at this cell cycle again, you can see that there's a pathway that includes those important proteins such as BRAF and the MEK protein. And these are important in proliferation of cells. And the reason this is important is that if we identify this BRAF mutation or fusion or a MEK alteration, then this would be a target for treating those tumors. And these are some of the medications that are available now in what we call targeted treatment for astrocytomas. We have BRAF inhibitors and we have MEK inhibitors such as selumetinib, trametinib, and others, and we are incorporating those in the treatment of pediatric astrocytomas nowadays. This is an example of a patient with a low-grade tumor called ganglioglioma, and the tumor was found to have this BRAF V600E mutation, and you can see after a few months of dabrafenib, which is a BRAF inhibitor, this small whitish tumor that you can see in the posterior fossa is almost half the size it was before. So a promising treatment now available for these low-grade gliomas. Now, in the malignant gliomas and other tumors such as atypical teratoid rhabdoid tumors, the pathway that's affected involves the histone and histone mutations. So this is an example of what we call diffuse midline glioma, and you see two examples. One is a large tumor, a glioblastoma in the midbrain on the left, and on the right you see the classic DIPG or diffuse intrinsic pontine glioma. We know now that these are diseases that are characterized by mutations in the histone gene, specifically what we call K27M mutation. And we're hoping that this genetic finding will help us find targets for treatment in the future. So when we refer to glioblastoma multiforme or high-grade glioma, you can see now, based on this classification and this table, that GBM is not one entity. It's in fact 5 or 6 different diseases. You can see in this figure that the K27M is one, as outlined on the left side of the table, and that's critical because when you look at the survival, you can see that the survival may range from less than 6 months to more than 5 years in the favorable types, such as the PXA-like glioblastoma. And in between, there are some other types that have varying survival durations. But in general, glioblastoma remains a very aggressive tumor, and that's where we need to find more effective treatment. Our most common malignant brain tumor in children is still medulloblastoma, and this is a tumor of the posterior fossa. And the molecular classification there has identified a variety of subclasses, which are mainly 4. You can see the first one is called Wnt, the second is sonic hedgehog, the third and fourth are group 3 and 4. And this is also important because the first subtype, the Wnt, is associated with almost a 100% survival. So this is an area where we're trying to reduce the chemotherapy and reduce the radiation so that we can cure these children without long-lasting or damaging side effects of the treatment. This molecular classification outlined in this circular figure has also led to the identification of novel entities. You may be familiar with the term we used in the past called PNET, or primitive neuroectodermal tumors of the brain. Now this has been changed, and we have found that this wastebasket diagnosis has in fact many subgroups that are more specific and more defined by these genetic mutations. For example, 4 of these types are the FOX alteration, we have the CIC altered tumors, we have the cerebral neuroblastoma, and the B-core mutated tumors. So now that we can identify these tumors more specifically, we think we can try to treat them more effectively. One of the other tumors that we see, and it's important in children, is ependymoma, and this is 3 major types: the supratentorial, infratentorial, and the spinal cord type. And this figure is complicated, but basically it shows you that there's really 9 types of ependymoma. But I'd like to point your attention to only 2 columns. If you look in the middle at the posterior fossa type, and you go way down, you'll see that there's 2 types of posterior fossa, the PFA and the posterior fossa B. And you can see that the survival curve for the posterior fossa A, which may stand for aggressive, is one of the worst of the categories of ependymoma. So this is where we're focusing our treatment now, to see how we can improve the survival of type A posterior fossa ependymoma by adding chemotherapy or other agents to our regimen of surgery and radiation therapy. And our radiation therapy has also developed significantly in the past decade. Radiation is still important for a variety of pediatric brain tumors. Medulloblastomas, high-grade gliomas, ependymomas, etc. are still tumors that need radiation therapy for treatment. So the developments are mostly in how we focus radiation on the tumor and protect the adjacent healthy brain from being exposed to radiation. And these are some of the techniques we're using. We have a lot of experience in Miami with the gamma knife technique for children, cyber knife, as well as proton beam radiation. And we'll talk a little bit more about that. The reason we want to reduce radiation or avoid it is because of the late effects that are associated with radiating the brain, particularly infants below 10 or below 5 years of age. So radiating the cortex would lead to neurocognitive deficits such as academic achievement, memory, fine motor skill, visual, hearing loss, and a lot of other psychosocial issues. Radiation can cause anatomic problems such as radiation necrosis, leukoencephalopathy, myelopathy. The vasculature may be affected. If you radiate the carotid areas in the suprasellar area, you may develop fibrosis of the subendothelium leading to stroke 5, 10, or 20 years after the treatment. Of course, endocrine deficits, if the pituitary hypothalamic axis is in the area of radiation, then growth hormone deficiency, thyroid deficiency, and many other endocrine disorders such as precocious puberty may develop. And then the traditional approach of radiation, where we gave radiation to the brain and spine, in the past led to thyroid cancers, soft tissue cancers, but also malignant brain tumors 10, 20 years after the treatment. So this will show you how proton radiation reduces that exposure of the brain. On the left, you see a radiation field for medulloblastoma to the posterior fossa. In red, it shows you the dose, the highest dose of radiation. And compare that to the traditional radiation called photon radiation, and on the right, intensity modulated radiation, which is an advanced technique, but still not as good as proton beam radiation. So we have shown, and studies have shown, that proton radiation reduces the late effects of treating brain tumors, such as neuropsychological deficits, endocrine deficits, and many other side effects. So in summary, we have reached the maximal potential for conventional chemotherapy and radiation when we treat pediatric brain tumors, and what we have to focus on in the new era is identifying molecular targets based on our genetic analysis of these tumors, so we can target those tumors more specifically and hopefully with better outcomes. Thank you for listening, and please don't hesitate to email or contact us for any questions or suggestions.